Good health can begin when barriers to optimal health for everyone are removed, which we know can be difficult. Meeting this challenge requires a paradigm shift and a collaboration between key stakeholders across silos to address the social determinants of health and their interlocking social, economic, environmental, and political systems. Change is possible when we focus on addressing upstream factors and as we cooperate as equal partners in health improvement. So I will turn it over to Dr. Geyer, and thank you so much for being with us today.
It's a pleasure to return for this final masterclass. And Angie, I couldn't agree with you more. Change is possible. And, we've had an opportunity to now listen to 9 masterclasses that have really covered the waterfront and all aspects of our model of population health that was adapted to also accommodate meeting individual health as well and improving it. So I have a couple of objectives for this presentation that I'll start with. There are only 3, and really my hope, I know yours as well, is that those who are completing our series with this final masterclass today are leaving with a sense of empowerment with what they've learned, and that they have some practical tools to know how to get to work and put into action what we've been discussing. So the first learning goal is for those who complete today to be able to integrate the information from this series to formulate an evidence-based plan of action for health improvement as a capstone learning experience. And this, of course, is at home. The second goal is to summarize the Health and Human Services call to action and explain why stakeholders must work across organizational silos to realize permanent change. And then finally, number 3, that each person is going to be able to propose evidence-based solutions that their community can use to implement and work across their silos to address upstream factors and improve local health outcomes. So let's go ahead and get started. I think this is just a beautiful picture of an upstream environment. And often when we talk about the social determinants of health, we challenge ourselves to remember that change takes place when we move upstream. The reason a beaver builds the dam upstream, is so that they can stem the flow and that they can get the fish and everything that are going to kind of back up. So we know that if we're going to change health outcomes, we need to move upstream, okay, to that preventive place, to that place where it all begins. Health is going to change when individual health-related social needs are met and structural barriers are removed. And meeting this challenge does require collaboration. A lot of us are good at talking to people who share our interests. We're comfortable with people that we know who are in our own organization. Oftentimes, the challenge comes when we realize that we need to work with people who are in different organizations. Maybe the mission is slightly different, or maybe the philosophy or approach is slightly different. And so there are some areas of navigation that need to take place in establishing, those new working relationships. But again, they really are necessary if we want to see permanent change. So the Department of Health and Human Services in 2023 issued a call to action. And I got really excited when I saw this call to action because it resonated with me and the work that I do locally here in Florida in Alachua County. And I live in the city of Gainesville, which is really the urban hub of Alachua County. So Health and Human Services is calling upon individuals who work in healthcare, social services, public and environmental health, government, and health information technology to partner and work together across silos to address the health-related social needs through community partnerships, to improve the health and well-being of every American. And I hope it's not too distressing that I took the time to actually read the words word for word verbatim from the call to action, because I think they are so powerful and so complete as written. I couldn't have paraphrased, I don't think, and done a better job. So, Health and Human Services has been working with the Centers for Medicare and Medicaid, CMS, and also with accrediting bodies like the Joint Commission uh, to paint the picture of a future that is brighter and that offers the same health opportunities to every American. So, Health and Human Services does see a future in which everyone, regardless of their social circumstances, and that's what's important to focus on because, again, the social determinants of health include not only the social circumstances of the environment, but also the economic and the environmental. So, again, we need to work together. They've aligned health and social care systems that achieve equitable outcomes through high quality, affordable, person centered care. So, working in partnership with CMS, the healthcare system is really shifting, and it has been gradually shifting for the past, probably since about 2017. Um, and the reason that shift is taking place is because our government organizations recognize that if we're going to eliminate health disparities, that we have to identify and address individuals' social risk factors like their financial strain, their housing instability, their food insecurity. So, going back to those individual health related social needs, this is the only way that we can make a difference because these health related social needs, when they aren't met, contribute to poor health outcomes that are resistant to change. So, organizing from different sectors within the same community is the way to make progress and move forward. So, it's not unusual for healthcare, perhaps, and public health to work together, but we're saying that we need to reach even further across the aisle. We need to reach out to the business community. We need to ensure that government, our administrators, and our elected officials, that we're reaching out to them to talk about needs as we see them because we work with them on a regular daily basis. We need to make sure that they understand the depth of needs and what it will take to meet needs within the community. And if there are priority populations with special needs, again, it's really helpful to be able to educate them about what those needs are in the community. And Masterclass number 3 did a great job of helping us to understand how we can advocate using stories. So here's our opportunity as individual organizations working within the sectors that we are part of to talk to people who are challenged by unmet health related social needs and take time to tell their stories. Maybe put them on our websites or post them in our newsletters. There are so many creative ways that we can share the news about how life for some in our community isn't reaching its fullest potential. So it's the cross-organizational and cross-sector collaboration that should include not only the different sectors within a community, but also the people who are living with daily challenges. So their lived experience is very important to include in this process of change.
I love that,
So,
Laura, because you know, in the accreditation process, they encourage us to find those non-traditional partners, those people that
mhm,
we normally would not
right.
bring to the table, and reaching out and going into the communities and getting their feedback because it's totally different than from what we thought it was. We
Mhm.
have to hear from them. So I love what you're saying here.
I came from a meeting this morning of the Alachua County Safety Net Collaborative. SNC is what we call it. And I'm going to be using SNC as a model to share with everybody toward the end of my final masterclass today. But the Safety Net Collaborative locally, one of our pet projects has been looking at access to information and do people have the information they need about the resources that are available, right? So that they can take advantage of them when they need them. And oftentimes that is the most difficult thing to do. Here you have, programs with funding, you have resources, and you're just waiting for the people that you can help. They don't know about you, or they don't have current information about you and your programs. So again, I'm excited because we talked about um, access to information through 211, which is with Our United Way. 211 is in many communities. We also use Find Help. That's another national database with information about community resources. And we are trying to find ways in our community for 211 and Find Help to partner together so that we don't have to choose. We can have it all. I don't want to have to. I guess I've reached the point in life where I don't want to have to choose anymore. I want all of it. And the best conjunction for me is and, not or. So I'm going to go back to the very beginning of the planning for this masterclass series. And when I was contacted by the Mississippi Public Health Institute, I started with the 2022 Mississippi State Health Improvement Plan. And I know that's a document you are intimately familiar with because you were part of the steering committee and all of the planning and the execution that subsequently took place. I started with the State Health Improvement Plan because I knew that would help me understand what the health needs were in Mississippi. And you had two priority areas in that document. First, to fight obesity, to manage chronic disease, and second, to improve the social determinants of health. So that was the starting point. And then, as folks will remember from masterclass number 1, we then expanded the reading to include the state health improvement plans for the other 7 states that are in the Southeast region because our grants wanted us to focus on improving health outcomes in the Southeast region. So our master classes, the topics that we covered, came directly from reading and evaluating and distilling down all of the priority areas that were listed on 8 different state health improvement plans. And this is how we arrived at the 10 topics that we have discussed in class. So just as a reminder for what they were, the first class, we talked about the social determinants of health, the starting point for health improvement. The second class was the framework of the rural health support system. Third, using storytelling as advocacy. Number 4 was nourishing the future. We had a wonderful conversation about how food access and strategic partnerships and policy, so we're pulling classes together already at that presentation, could transform community health. Masterclass number 5 looked at reading between the lines and addressing literacy, and state of Mississippi gave us a model. You all are, again, just really doing an outstanding job of leading and changing the future for your children by the legislative changes that you've implemented. Masterclass number 6 was Prepare, Activate, Engage, a 21st century model for provider appointments. So communication has changed, expectations have changed, healthcare has changed. Number 7, improving maternal and infant outcomes through mental wellness initiatives. Number 8, master obesity and diabetes, and Dr. Farrow encouraged us that we can do it. Masterclass 9 was tobacco cessation, and then here we are today at masterclass number 10. So I thought it would be really useful and interesting to pull from my memory some of those outstanding points in the different master classes that were examples of the topics we're discussing, but incidents where you saw that they were working together. So one of the first that stood out to me was really in that first class where we looked at the social determinants and we looked at the upstream factors, recognizing that all of these factors fit together, they unite as a model of health. And so, addressing those that stand out on the state health improvement plans will certainly effect some positive change and in health. One of the other, and Angie, you may have some favorites yourself. So if don't mention your favorites, feel free to add them in. So, we talked about relationships with lawmakers and realized, Pandora Redmond helped us realize that she has relationships with lawmakers. She even spoke at the State House. And it's when you have relationships that you can then move access to healthy food forward. And she also mentioned something. She said she talked about her great grandmother who lives in the Delta area, where hunger is such a huge problem. And people are hungrier in the Delta area than any other part of Mississippi. And she commented on the fact that her grandmother didn't read well. And she said, I don't want to say illiterate, but she doesn't read well. And again, thinking about how the different topics fit hand in glove together. Throughout several presentations, we talked about laws and legislation and change in policy. And certainly it was new legislation that was passed that has led to the increase in fourth grade reading scores. And now the state of Mississippi, instead of being at the bottom in the nation, is right up there toward the top and number one in some areas. We know that legislation was also involved with the tobacco settlements in our individual states. And that legislation has driven dollars and resources back into communities in our states for education and tobacco cessation. So, Dr. Hanses gave us that example when in masterclass number 9. We talked about chronic disease management, and we realized that, or Dr. Farrow helped us realize that chronic disease management really begins very simply with having access to healthy food and eating it and taking care of your oral hygiene. We know that patients who can read and have numeracy skills and can problem solve are going to manage their health better. That was something that Alyssa Hobart taught us about. We know that people who are prepared, activated, and engaged to interact with their health providers are going to be more satisfied with the experience. They're going to have better health outcomes. We're going to have reduced healthcare costs. And we know that, again, they're going to have a much better experience, as well as the providers. It'll be much more satisfying and positive experience. We learned in masterclass number 2 that people in rural areas have less access to healthy food, less access to healthcare, and to quality education. And those are 3 topics that we discussed in masterclass. We know that new models of care, like the rural emergency hospitals, they've been established through the advocacy efforts of people living in their states. Maternal mental health can be further compromised when women use substances like tobacco. So again, we want to have some partnerships. And then the evidence-based, culturally responsive programs and peer support. We learned that they are effective when addressing a number of issues like tobacco cessation. We know that those evidence-based programs and peer support really improve maternal mental well-being, that they promote healthy eating habits around the family dinner table at night. They help us to continue with exercise or walking programs, increasing our activity, and they do help us to reduce stress. So I'm excited to get started and introduce Alachua County, my home, to you as a model of something that we've been doing well, working across the silos since 2013. So welcome to Gainesville. Let me tell you a little bit about my community. Those of you who may be familiar with Mississippi, maybe the central part of Mississippi, Rankin County, where most of the recording of these master classes has taken place. I had never been to Rankin County, Madison County before. I was so shocked to see that when I opened my eyes and looked around, it looked just like home. You had crepe myrtle trees, and the environment. It was hot and muggy, just like Gainesville. But it was just like home. So, we're representing 8 different states, and I thought it would be useful to give you a little background about what Alachua County in north central Florida is like, and the city of Gainesville specifically. The state of Florida, if you've never been here before, is almost like 2 states in one. The northern part of the state is much like South Georgia and Alabama. The southern part of Florida is very diverse with people who speak a variety of different non-English languages as their first language. And there are other differences as well. Here in the northern part of the state, I'm going to share some demographics with you so you can also understand the population that lives here. And as I do so, you're going to want to keep in mind some of the demographics that we looked at for your individual states. So welcome to Gainesville. It was ranked as the #1 best place to live in America by Money Magazine in 1995. That seems like a long time ago now, but it really wasn't. We are and have been Tree City, USA, voted and designated so by the National Arbor Day Foundation. Here's an interesting one. We are number 11 at the top 15 best places to reinvent your life. AARP gave us that interesting award in 2003. I think this is still a very interesting place to reinvent your life, and I've been here a long time. And just recently, this year, in fact, just about a month ago, we were certified as an official Bee City USA. So, a lot going on here in Alachua County. So, here are some quick facts that I think are interesting. We are home to the University of Florida. That is the flagship university here in the state of Florida. We were ranked as high as number 5 with public universities a couple of years ago. Our total population, 2023, 285,000, almost 286,000 people. Half of the population of the county lives in the city of Gainesville. So, the city of Gainesville is the county seat. And I want you to know that all of the cities and towns around Gainesville are very rural. So, the median age, 25 to 34 years. This explains my social life really well. It's a very young group, although it is increasingly becoming older because we're seeing people from South Florida move to North Central Florida to escape hurricanes, and because we have so much beautiful land that's available. In terms of thinking about language diversity, we have 15% of the population in Alachua County that speaks another language besides English as their first language, whereas in the state of Florida, it's almost 30%. We have a very highly educated population, as you might imagine, here in Alachua County. The highest earned degree being a bachelor's degree, almost half, as compared to only about a third of people in the state of Florida. So very highly educated. So it's easy for people who graduate sometimes to find a starting point for their careers and jobs, but there's not a lot of opportunity for you once you get established and start to grow and rise into the middle part of your career rankings. The median household income is lower than the state average. The percent of persons in poverty is much higher. I will describe Alachua County and specifically the city of Gainesville to you as a town of the haves and the have-nots. And in Gainesville, Main Street, which runs north-south, is the dividing line between East and West Gainesville, where the haves live on one side and the have-nots on the other. I'm going to show you also that Alachua County is one of 2 counties in Florida. We have 67 counties in our state with the greatest income inequality. And here's the picture that I was talking to you about. So income inequality, and you can take a look at this map. It's one that was developed by the Robert Wood Johnson Foundation. You can see that there are 2 counties that are the darkest blue color. Alachua County is the one at the top, and there's another county just adjacent to the Tampa, St. Pete area where income inequality is also very great. We know from the research that in every nation, there is a health wealth gradient. And what that means is that those who have the greatest wealth usually have the best health as well, because it takes socioeconomic means to manage your health, to pay for your health. But I also, through the lens of the social determinants of health, want to express the point that when you have socioeconomic wealth, then you have greater access to all of the social determinants of health. We know that when you live in a community with greater income inequality, that it exacerbates issues. People don't feel as socially connected. You heard me describe Gainesville, the city of Gainesville, as a city with the haves and the have-nots. Well, certainly that's not a connected sounding term. There's decreased trust, decreased social support, and there is a decreased sense of community. We have a number of nonprofit organizations that work very hard to create a sense of community and to find a way to offer inviting spaces and opportunities for newer neighbors who may be immigrants or who may have come from another part of the country, to feel welcome and included and part of the community. We know that income inequality can impact health also, because it increases your risk of early death and certainly of dying at less than the average age. You have an increased risk for poor health and for specific diseases like cardiovascular disease. We saw that in the Southeast region that obesity and diabetes are very common problems, and certainly they are here in my community as well. When we take a look at the health outcomes and the health factors, remembering that our health outcomes are the length of life that you live, and our health factors are those factors that we can improve now. So this is why I get excited about the social determinants of health, because they do affect our quality of life. And often these are factors that we can improve now. They're under our control. So as you see Alachua County and located here on the map, and it might be easiest to see if you start on the map to the right with the blue and purple and pink colors. So again, toward the top of the state, right in the middle, you see that blue Alachua surrounded by a sea of pink and darker pink, because the quality of life in Gainesville is better than it is in the sister counties that surround us. And we find the same thing with regard to our length of life. So not only quality of life, but length of life. You can see that Alachua County is in a darker shade of green when compared to the other counties that surround us. So I live in North Central Florida, and to help you visualize what North Central Florida encompasses, these are the 12 counties that are most commonly referred to as North Central Florida. And you can see where Alachua County is located, right about in the middle of this map. And here are the demographics that I wanted to share with you. I'm not going to go through each one individually, but if you take a look at the social determinants of health in Alachua County cities, and I've listed the cities that have more than 5,000 people living in them. So I separated East Gainesville from West Gainesville because it in some ways is almost like two separate cities. We have the city of Alachua, and the city of Alachua is in Alachua County, so two with the same name. We have the city of Hawthorne, we have the city of High Springs, and we have Newberry. So Gainesville, Alachua, Newberry, High Springs, and Hawthorne are the 5 cities whose population is 5,000 people or more. When you take a look, you can see that with regard to the population density, we certainly have more people in West Gainesville than East Gainesville. You can take a look at demographics in terms of race and ethnicity if interested. You can see that the percent of individuals who have an income of 50,000, 30,000 or less. The smaller towns, certainly, and East Gainesville when compared to West Gainesville. You can take a look at diversity in terms of language and who speaks a language other than English at home and see that there's greater diversity in East Gainesville and much less so in our smaller rural towns. You can also take a look at the median home value. You can take a look at the real estate taxes, which I think are really interesting because our real estate taxes, our property taxes, provide support for our schools in terms of resources. So why do we often find that schools that have better scores are located near maybe communities with greater wealth? Well, often it's because, again, the property taxes are supporting and adding resources to those schools. You can take a look at education and see how it varies between East and West Gainesville and among some of our smaller rural towns. And you can also take a look at other social determinants like transportation and identify some key differences. So the Safety Net Collaborative was established in 2013, and Angie, you'll find this interesting. It formed organically out of the steering committee for the 2012 Alachua County Health Improvement Plan. So our local health department, this was their first effort to become accredited following, the publication of the accreditation guidelines requiring that you complete a health assessment, and then you also complete a health improvement plan, and that was established in 2010. So a couple years later, we're ready to go because our local health planning council was already completing the community needs assessments on a periodic basis. So we had a group from the steering committee. We also had a small group that was meeting in our community under the leadership of one of our local physicians. And these two groups were meeting really with the same purpose in mind. They wanted to build closer working relationships with one another. They recognized the need that was in Alachua County and in Gainesville specifically. Just before this time, there were a number of national publications about health disparities that took place. PBS had a special that was looking at health disparities in different communities. We were having a lot of conversations in our community surrounding the question, is healthcare a right or is it a privilege? And that was about as much as we understood, but we knew that the answer was it shouldn't be a privilege. Should it be a right? Well, we think everybody should have good healthcare. Everyone should have access to healthcare, and we were looking for innovative ways to make sure that that took place. So the two groups merged the end of 2012, and 2013 established this new name of the Safety Net Collaborative, and we represent two safety nets. Our members represent the healthcare safety net, and they also represent the social services safety net. We meet as a group around almost like a round table because we see each other as peers. We don't have a formal structure where one person is in charge. We share needs. So one organization will provide a meeting venue. Another will provide the moderator for the meeting. We collaborate to meet one another's needs as well as to meet the needs perhaps of individuals in our community who have extreme needs. Again, the goal to build relationships and share information, and the members come from all different sectors. So this is the formal mission that we establish. Again, we unite to work across the silos. So you can understand why when I came across the Health and Human Services call to action, and it said work across silos, that I thought, oh my goodness, maybe this is something that the Safety Net Collaborative needs to take a closer look at, because this is something we've been doing, and because it's a sincere conviction of ours since 2013. So We work across silos to remove barriers and close holes in the healthcare and social services safety net. We build relationships that are trusting with one another. Sometimes that's hard to trust someone else, especially if you know you're submitting a grant. Maybe they're submitting a grant for the same to the same agency. What we've started to do in our safety net meetings is to make grants a topic of conversation and ask who's aware of funding opportunities, who's looking for partners to collaborate with, who needs letters of recommendation. Again, our grants are stronger when we have partners, and what could be better than partners who share your same vision, right? In terms of the mission of why you exist. Our governance, we are an independent, egalitarian, nonpartisan, interprofessional, and interdisciplinary organization. A lot of descriptors, all put in place to say that we're not a nonprofit. So, people come to the meetings and participate in events because they want to be there. And they believe that their participation is going to make a difference. We do build relationships with one another. I'll tell you what, I make it a purpose to go to lunch with somebody every week that I don't know well, because Gainesville, being a university city, has a lot of transition. So we have people coming and going on a regular basis, and it's easy to get comfortable with the people you know, but I deliberately seek out the people I don't know to learn about who they are, learn about their programs, maybe schedule them to talk, at a safety net meeting to share with the rest of the group about what they're doing. This slide shows the names of the more than 80 different programs and organizations who are participating in the Safety Net Collaborative. And as you look at the names here, you're going to say, well, I don't know what a lot of these organizations, I can't tell from their names what they do. The point that I want to make is that our email list is extensive. All of these organizations identify as part of the safety net because they provide healthcare or social services. And they remain on the email list because they want to stay abreast of the news, get involved with activities, and again, know who's in the community, because this is a great way to stay abreast of those who are newer members. So we have worked on a number of initiatives as an informal organization to increase access to information and community resources. Probably every provider who is participating in this series, and students who perhaps are either volunteering or working at organizations while they're in training, that you have something called a resource list if you have a clinic, and that resource list has the names of all the organizations that you refer people to when you can't meet all of their needs. So, for example, we have a mobile outreach clinic, and they regularly refer people after meeting their healthcare needs to the food pantry. They will refer them for social services like maybe utilities or assistance with transportation or housing. They also might refer people for different needs, like maybe language, if they don't speak English well and they want to improve their language skills, or maybe they have someone who never completed high school and they want to complete with a GED. They can refer them to those programs because they have a resource list. Well, anybody who's used a resource list knows that they go out of date really quickly because programs are constantly changing their services and their times and people. So we, recognizing that our community is transient, in 2015, I was teaching a large group of undergraduate students interested in health careers. And we decided that as a public service to the safety net organizations who were already working on a shoestring budget with volunteers, that we would undertake the responsibility to take all of their resource lists and combine them together as a master resource list for the Safety Net Collaborative. And so from 2015 until 2020, we did that. The undergraduate students did. And this master list grew and grew and grew until it became a document that could be downloaded, and it was more than 100 pages and 125 different organizations who wanted to list their programs and services with the safety net community. Then we had COVID. Y'all may remember that 2020 was a year of change. During that year, we used the resource guide that was published in 2020, and then starting in 2021, we moved to a different resource called Find Help. Some of you may know that as Aunt Bertha. It's a national online database that you can type in a zip code number and ask for housing or ask for food, and you'll get a drop-down menu of places that you can visit that are in that zip code area. What we discovered is that we were using Find Help for its most basic service, which is to connect people to programs and resources, by zip code. But there are a number of more advanced uses for Find Help, such as you can make closed loop referrals. So UF Health Shands, our academic medical center, has embedded Find Help in its patient portal and has almost 1 million patients in North Central Florida who receive their health care at UF Health Shands or one of its associated hospitals. Well, Find Help is embedded into all of the patient records. Well, I am meeting with my chairman in the Department of Community Health and Family Medicine to say, we might want to take a look at how, as we screen for health-related social needs, and once we start to realize that screening, if you're going to screen, you need to then follow through when you find needs and meet them. Our department doesn't have enough social workers to meet the demand to help everyone with needs meet those needs. Nor does the UF Health system have enough social workers. So what are some creative ways that we could perhaps partner, perhaps family health, primary care or internal medicine with the Safety Net Collaborative, because our programs are the needs that your patients have. So maybe we could use Find Help to make closed loop referrals from your clinic to the individual organization. So that's one possibility that we're looking at. And there are a number of different possibilities. You can download data so you can use this information for research or for program planning. Some of our county commissioners are very interested in seeing what might transpire in terms of data that they could download from Find Help as they see what kinds of programs or needs are in highest demand. They're thinking that perhaps they could use the database then to direct funds into programs or direct funds into different areas of town. So right away, we see the application of the upstream factors, those political determinants of health that drive the resources, the money, and the programs into different locations. And that's something that our community is taking a close look at. So we've talked about evidence-based approaches throughout this masterclass series, and I thought you might be interested in knowing if our approach and kind of what we're doing, our model, is it evidence-based? And so what we find is that the evidence ranking is for expert opinion, and it does have the potential to decrease disparities, which is, again, great news to us because that's exactly why we formed from the beginning and is one of the reasons that we continue to meet. You can see that there are both expected benefits and potential benefits, and all of them, again, fit within our mission and fit within, the goals that we have, not only for ourselves as a safety net collaborative, but also our individual organizations. So here's my question to everyone who's joined us throughout the series. We're at the end with class number 10. And now that you've heard all of the evidence, you've completed the classes, you understand why the social determinants of health are important and how you can use them, how are you going to respond to the call to action and improve health in your community? I truly believe that we as a nation, you and your community, all of us as individuals, are limited only by our imagination. So I want to encourage you to imagine wildly. Think outside of the box and be creative. If something didn't work in the past, don't be afraid to try it again, because the past is gone. And the people who tried it in the past are gone. And this is a new day. We have technology that maybe didn't exist then. We have different people involved in the planning process. And anything is possible. So, we're at the end, Angie. So I guess together we can thank everybody for joining us and completing the series. And we can say one last time that we've reached the end and class is dismissed.
Thank you.
Thanks, everybody.